So welcome everyone to our inaugural WFPICCS Traveling Around the World global webinar. It's wonderful to see so many names. Although we're running a webinar, so wouldn't be seeing your faces today, but I can see quite a lot of you are here. So thank you so much. And I can see it's from a global audience. Now, the goal of these webinar is, in addition to stimulating you for a conference that we'll be having soon, one of the main goals is to see how we can support and share our experiences between low resource countries and high income countries. And we've had a number of colleagues who have asked us for help with their patients. Because there's a deficit of intensivists and sometimes resources in those countries. But in addition to that, we have started programs in many low-income countries, and my colleague Amelia has been doing some fantastic work in Kenya. Today, we are privileged to have two young budding intensivists from two of these programs, one from the continent of Africa and one from the UK. Where they will present two of their cases. But in addition to that, we have a world expert speaker, Dr. Martin Niebuhr, who will give a talk to manage the theme of the situation. Before we launch into the program today, we have a small poll that I'll ask Evelyn to pop up on the screen if we can get that. And if you can spend a minute or so answering those questions, and Emily will introduce our first speaker. So if you guys can answer some of these polls question before the talk today. Remember, it's supposed to be really engaging. So if you can drop lots of questions in the Q&A box and we can discuss that at the end of the session. Again, welcome everybody and looking forward to a really engaging session.
Sorry.
Amelia, you just need to unmute yourself. Yeah, awesome.
Oh, here we go. Hi from good morning from Seattle. My name is Amelie from Saint-André. I am a pediatric intensivist at Seattle Children's and the University of Washington. And I am really excited to present one of our pediatric emergency and critical care fellows, Dr. Adnan Mustafa, who trains with us at the Pediatric Emergency and Critical Care Fellowship at the University of Nairobi, which is a collaborative program between the University of Nairobi and the University of Washington. Dr. Adnan Mustafa is originally from Mombasa in Kenya, did his medical school at the University of Nairobi and his pediatric residency at Moi University in Western Kenya, and now since last year is training with us in Nairobi and Kijabi Hospital in Kenya, and we are very, very fortunate of having him. He's an excellent budding pediatric emergency medicine and critical care doctor. And he will be presenting a case from Kenyatta National Hospital, which is one of our major training sites, and describing how in lower resource settings, he is able to take care of patients with pediatric ARDS. So Adnan, the floor is yours.
Hi, thank you very much.
Before we end, Evelyn, can you just pop up the results of the poll and then we'll go into the presentation. Thank you. Exciting results, but over to you, Adnan.
Thank you. So my name is Adnan Mustafa, and I'm a fellow in pediatric emergency and critical care at the University of Nairobi and practicing at Kenyatta National Hospital. This is our national referral hospital. It's a tertiary center. And our pediatric intensive care unit is located on the second floor. So from 2011, we had a general combined adult and a pediatric ICU with a pediatric intensivist on board. And from 2015, we have 5 bed separate pediatric ICU, which is open, and the beds are only 1 meter apart. However, the adult ICU help us with overflow patients. And from the year 2019, the Pediatric Emergency and Critical Care Fellowship Program was started. So this is our PICCS, the 5-bed PICCS. Here it is empty, but most of the time it is not. So to the case presentation, 2-year-old previously healthy female presents with a 2 to 3 day history of fever, cough, and worsening respiratory distress. Initially was admitted to a county hospital for 1 day with only oxygen available for respiratory failure. Arranging a transfer to Kenyatta National Hospital for intensive care treatment took almost 1 day. So in the pediatric emergency unit, on the vitals, she was febrile with a temperature of 37.8, tachypneic with a respiratory of 70, and tachycardic at 158. Was hypotensive with a MAP of 46. The saturations were 80% on non-rebreather mask, and had features of respiratory distress with chest wall indrowing, grunting, and bilateral coarse crackles. Cardiovascular had cool peripheries with a capillary refill time of 4 seconds, normal heart sounds, and no murmurs. Her GCS was 10 and was lethargic. So while in the pediatric emergency unit, there were no beds available in the pediatric ICU. However, got space in PICCS a day later, and was intubated, and mechanical ventilation was started with on the pressure control mode with a PIP of 26, targeting a tidal volume of around 6 mL per and a PEEP of 7. She was acidotic with a PSCO2 of 65 millimeters of mercury, and she was given volume resuscitation, a total of 40 mL per kg of ringaselected, that is 20 mL per kg twice. And after that, put on inotropic support with adrenaline at 0.1 mics per kg per minute, and also started on ceftriaxone for treatment of shock. The hypoxemia progressively worsened with SpO2 of 70 to 80%. Acidosis also worsened with a PSCO2 of 88 millimeters of mercury, mainly respiratory acidosis, despite being on a FiO2 of 100. The PO2-FiO2 ratio was 50, which is indicative of severe pediatric ARDS. The PEEP, positive end expiratory pressure, was we did up titration of it, starting going to 10 and finally to 12. So this is the chest X-ray ordered on day 1, or rather on admission, but unfortunately performed on day 3, where you can see bilateral opacifications. Subsequently, there was poor air entry in coarse crackles bilaterally, and with a P of 12, she managed SpO2s of 88 to 90%, but on a FiO2 of 100%. She still had cool peripheries despite, and a cap refill time of 3 seconds despite being on adrenaline. Because of ventilatory asynchrony, she was done atracurium intermittently, and chest physiotherapy was prescribed 6 hourly. We started proning at daytime. Nighttime proning was not possible because we didn't have enough staff at night. The nursing ratio was not adequate. After prone positioning, there was gradual improvement, there was better oxygenation, and the PO2 or FiO2 ratio increased. And when settings of wind and improving aeration, she tolerated extubation readiness test at day 8. The hemodynamics improved, and the adrenaline was stopped. There was successful extubation on day 9. Because of a high mortality rate that is post-PICU discharge, we had to keep these to make sure she's very stable. So we had to keep her almost ready for this hospital discharge. So on day she was discharged to the general wards on oxygen at 2 liters per minute via the nasal prongs. There was no respiratory distress, and the hemodynamics were normal. So the challenges in low-income resources settings, we have late referrals. Children stay in county hospitals or rather peripheral hospitals for quite some time where they don't have intensive care units before being referred to a center. And there is also lack of adequate critical care supports. Many times the patient come by their own means, like a taxi, or even if there is an oxygen, many times even if there is an ambulance, many times there is only oxygen in the ambulance, no monitors. As you see, we only have a 5-bed PICU, so there is limited ICU bed availability. As you can see, one in the case, the child didn't get the PICU bed immediately. Invasive positive pressure ventilation. The interfaces are not readily accessible. So patients either stay intubated for longer or don't make it to intubation, either because of no PICU bed availability and even weaning down to non-invasive positive pressure. So at our PICU, the challenges we face is limited monitoring. In terms of we are not able to do end-tidal CO2 monitoring and invasive arterial blood pressure. So we really have to rely on blood gas analysis. We have a delay in obtaining a chest X-ray, and as in this case, it can take up to 3 days. So there is one portable X-ray which serves the whole hospital, a 10-floor hospital. And if the portable chest X-ray breaks down, we have to wait for it to get repaired. There's also limited staffing in terms of the nurse to patient ratio is 1 to 2 at daytime and worse at night. There is no PICU doctor, a PICU specialist doctor in-house overnight. It is usually officers. There is limited equipment. For example, in this case, there was a dilemma. We didn't have any inline suctioning. So dilemma with de-recruitment with each suctioning. Study done by Inglis et al. Looking at the optimizing respiratory management in resource-limited settings found out that there's the common equipment and infrastructure challenges. There is absence of training or technical support to operate the ventilator, no biomedical engineers to maintain and repair equipment. Usually machines are sold without a maintenance contract. There are multiple brands either due to poor procurement processes or due to donations with different brands, and frequent need to reuse single-use components like tubings, like the prongs for the high flow nasal cannula, high flow machine. There is poor access to spare ventilator parts, unreliable oxygen supply, and inconsistent electricity. Also for monitoring, pulse oximeters or monitoring SpO2 is very much available, but capnography, as I mentioned earlier, is rarely available. ABGs mainly in the peripheries are not available. Few drug pumps, like if you need to give many drugs via an infusion pump, sometimes you could miss. This patient was on adrenaline, was on sedation, initially required IV fluids, so many syringe pumps would be required. Lack of on-ventilator imaging. We don't have a specific portable chest X-ray for our unit, and it applies the same in many PICCS. And absent or poor quality of drugs, especially opiates. A study done by Riviello et al. In Kigali, they were looking at the incidence and outcomes of ARDS in Kigali, and they found that they used the Kigali modification, which had used non-invasive. They didn't use positive pressure ventilation. The SpA2 FiO2 ratio was more than 315, and by ventilation either on lung ultrasound or chest X-ray. They could not also rule out cardiac disease by imaging. They just rule out cardiac disease on clinical examination. So 4% of patients of all admissions had ARDS, and 30% of them were admitted to PICU, and 50% had a 50% mortality rate. And if they were to use the Berlin definition, they wouldn't identify even one patient. So there are challenges. These are the challenges we face, and we hope that these forums could help us more in managing the patients and identifying gaps and identifying how we could manage these patients better. Thank you. So this is our pediatric emergency critical team, and despite having hesitancy for COVID vaccine, we were among the first departments to get the vaccination in Kenya. Thank you once again.
Thank you, Adnan. That's a fantastic presentation, and it really brings up some of the challenges. I really like your discussion as it refers to the definition, and I think Martin will touch on that a wee bit at the bottom of the session. So it brings us from one area of the world where there's limited resources to another area of the world where I suppose you have a lot of resources to your disposal, but it comes back to your clinical management of these patients. And I would like to introduce one of my trainees, Dr. Argodi Swarup, who is a pediatrics specialist training in pediatrics critical care in the UK. Swarup is originally from India. He's worked in Leicester, he's worked in Great Ormond Street, and then he applied to become a pediatrics trainee in the Royal College program within the UK. He is currently now a second-year trainee at Birmingham Children's Hospital, and I'll hand the floor over to Swarup to discuss his case.
Am I audible? Okay, can you see my slides? Okay, thank you, Zaf, and thank you, WFPICCS, for this opportunity. I think it's just an honor to present to such a wide and global audience. So without wasting any further time, I'll start with my case. This was a case of pediatric ARDS, which we managed at Birmingham Children's Hospital. And while, hang on, my slides are not moved. Oh, yeah. While going through my presentation, I plan to cover the following objectives. I'll briefly touch upon the pediatric ARDS definition. I'm sure Martin will cover it in more detail. And then going on from there, we'll discuss our case and share with you the evolution of our case and how the pediatric ARDS severity increased in our case. Then I'll touch upon some early rehabilitation interventions that we were able to do for our patient. And then finally, I'll come to some unique challenges in managing this patient on our unit. So coming to briefly to the definition. So the PALIC 2015 consensus statement was a landmark new set of definition that included pediatric patients as a separate entity in the definition. And I think I'll not dwell too much into all the tables, but basically it not only included oxygenation index, but also oxygen saturation index as one of the markers which you can use to stratify the severity of pediatric ARDS. And it was especially helpful for patients who would not have an arterial line or who would not have a PaO2 reading. And as Adnan mentioned, that we don't want to miss pediatric ARDS patients. I'm sure there's still a few patients who might fall off in resource limited settings to define ARDS, but I think the goal is to try and include as many patients in the definition as possible. The definition also includes at-risk patients. And again, it tries to include all the modalities of non-invasive ventilation, including facial oxygen, CPAP, and high flow. And I think important to remember is when you're calculating the oxygen saturation index is to try and win the FiO2 so that you get saturations that are less than or equal to 97%, and then use that FiO2 to calculate the oxygen saturation index. I just spent a couple of slides on the calculations because these are simple, but sometimes a small error in these calculations can make a big difference to how we manage a patient or how we refer a patient. So these are kind of straightforward calculations, but it's important to remember the units. So if most of the ventilators will calculate mean airway pressures with centimeters of water, but the blood gas machine may be calculating it in kilopascals or millimeters of mercury. So it's important to know what units you're using and converting it appropriately. The other thing which I have been caught off guard is the use of online calculators. I think sometimes I've used them and found the OI to be different to what I have calculated it myself. And then I found a paper in Archives of Diseases in Childhood, again, specifically mentioning this problem. And I think there are a wide range of online calculators available, but some of them give an error when calculating OI. So it's always good practice to use this simple yet important calculations and calculate your OIs or PF ratios yourself. And again, it has got, as I said, it has got important implications, not only deciding the treatment strategies, but also when we are moving patients around from peripheral hospital to a pediatric intensive care unit, we need to know what these numbers are to decide if there's a potential for them to need ECMO and to decide on the journey appropriately. So coming back to our case, so we had a 10-year-old boy who was of African descent. He had sickle cell disease, which was picked up on neonatal newborn screening. He was followed up after that. He was under regular follow-up with no issues, no hospital admissions. He only had a bit of asthma. Again, he did not need any regular inhalers for that, just needed as and well bronchodilators when he was wheezy. And he presented to our local district general hospitals, as we call them, with a 2-day history of cough, fever, and difficulty in breathing. He was appropriately thought to have acute chest syndrome and was treated with antibiotics, pain relief, oxygen, and bronchodilators. This is his journey in the local hospital. So on the day of admission, as you can see, he had some infiltrates at his lung bases. On the second day, he showed a little bit of improvement. But on the third day, he developed some AKI, acute kidney injury, and became oliguuric, and his urea and creatinine went up. With the sickle cell disease in the background, he was given hyperhydration, and he was also started on some high flow nasal cannula. But subsequently, on the 4th day of his illness, he worsened again. He had profound hypoxia. He needed a lot of oxygen on his high flow. And as you can see on this X-ray, he developed complete whiteout of his right lung, and he got new infiltrates on his left side as well. His condition further worsened to a point where he needed intubation and then needed transfer to tertiary pediatric intensive care unit. So this is our transport service. It's called PICCS. I've mentioned the website. It's a useful resource for guidelines which are used by our local hospitals. And as a transport service, we not only offer specialized transport teams who can move really sick children from district general hospitals to tertiary pediatric intensive care units, but we also offer advice and support patients who are needing high dependency level care in the district general hospitals itself. So For this patient, it was a challenging transfer for the amount of oxygen and the amount of support he was needing. As you can see, he was on really high ventilatory settings with a MAP of 26 and needing a high FiO2. And if you calculate the oxygen index for him, it was 31. So going back to this definition, he had an OI more than 16 and he had severe pediatric ARDS. So after admission to the pediatric intensive care unit, because he was already on such high pressures via the conventional ventilator, as a modality of lung protective ventilation, and especially somebody who you are struggling to ventilate, he used a high frequency oscillator. These were his initial settings. I'm sure Martin will go into more detail about high frequency ventilation, but these were his initial settings. And this is the Sensormedics machine that we use on our unit. The initial blood gas on these settings showed that we could ventilate him better. We got a better CO2 clearance, and his oxygen requirement also came down to 70%. There was a period of stability after that, and his oxygen requirement eventually came down to around 50%. Subsequent to that, we always try and get a diagnosis as to what is the causative organism. So we try to do a bronchoalveolar lavage, that is deep endotracheal suctioning, to get a sample and send it for virology and bacterial culture. And unfortunately, after that, there was a deterioration, and he possibly de-recruited, and his oxygen index went up to 60. And then we were really struggling to both ventilate and oxygenate him. So then the question was, what can we do next? So in this situation, we had, these were some of the options that were available to us. So as I said, we tried to recruit him again. We bagged him with some PEEP, tried to put him back on high frequency oscillator with incremental increase in the mean airway pressures. We were thought about prone positioning, but he was really unstable. His saturations were not coming up. They were still in low 70s. And he also was needing inotropic support. So we thought it wasn't safe to prone him at that point. And the PALIC consensus guideline does recommend high frequency and prone positioning in the management of severe pediatric ARDS, but there is limited pediatric evidence for this. And we look forward to the prospect study, which Dr. Martin is leading, and hopefully we'll have some robust evidence for these treatment interventions. The other options was nitric oxide. Again, on our unit, we do use it when our backs are against the wall, and which it was in this case. And we do have a certain group of patients where we see good response to nitric oxide, especially their oxygen saturations do come up significantly and quite quickly. But again, not all show response to nitric oxide, and the ones who show response to nitric oxide will show this response pretty quickly. So it was tried, and again, his saturation didn't improve much with nitric oxide either. So then the next step was to think about ECMO or ECLS, extracorporeal life support, which in this case was discussed with a multidisciplinary team. We've got a guideline for ECLS treatment or therapy, and we've got strict indications for patients who need respiratory ECLS support, and he did fulfill most of the criteria for ECLS therapy. So the decision was made to start ECMO or ECLS for this patient. In terms of the other investigations, the BAL grew parainfluenza. The HBS fraction for him was high initially, 55%, but post-exchange it had come down to 14%. He had a high white cell count and was appropriately covered with antibiotics. And we did an echo, which showed a good function without any evidence of pulmonary hypertension or any right-sided failure. Going on, the rest of his journey on PICU, I think on day 4, he presented to us on PICU. He had a significant right-sided effusion, which was drained using a chest drain. He was subsequently put on VA ECMO support. On the next day, he developed Harlequin syndrome. I'll not dwell too much in detail about it, but basically there was differential saturation. So the saturations in the upper part of his body were lower as compared to the lower part of his body. And he had a femoral VA ECMO cannulation strategy. So I think in terms of the reasons for it, there were multiple, but mostly he had got better from his, he was starting to get better from his ARDS and hypoxia. His cardiac output had started improving. His inotropic support had reduced, and there was more deoxygenated blood getting pumped out of his lungs because of his increased cardiac output. And this was causing more deoxygenated blood in the upper part of his body, whereas in the lower part of his body, because of the femoral VA ECMO, he had higher saturated blood. So with this situation, the plan was made to change him to VB ECMO because he didn't need ECMO support for any cardiac instability either. So this was done without any complications. And once he was stabilized on VB ECMO, then we allowed his lungs to rest, but also wanted his body to recover. We all know critical illness, myopathy and neuropathy can prolong ICU stay and affect outcomes. So we planned to wean his sedation quickly as soon as he was stable on ECMO. We woke him up to a point that he could communicate with his parents and with the other members of staff in a safe way without any issues with the cannulation site. And we started rehab on ECMO. Through the rehab, he progressed well. His chest got better, his X-ray improved, and he finally got decannulated on day 13. And because he's already under rehab and he was gaining muscle strength, as soon as we decannulated him or we took him off the ECMO circuit, he was ready to be extubated within a few hours. So he got extubated a few hours after coming off the ECMO machine, and then was started on some high flow nasal cannula oxygen. Subsequently, within 3 days of that, he was discharged to the ward, and then 15 days after that, he was discharged home. So these pictures are put here with consent of the family. Again, you can see him sitting on the edge of the bed with the physios supporting him. We have got a kind of a cycle which he could use while he was laying on his bed and while still on ECMO support. And with this great multidisciplinary team that we have, we could really support him in this recovery while still on ECMO. At the same time, we also made sure that he was getting proper nutrition. We've got a full-time dietitian who comes and assesses calorie requirement, protein requirement. As I said, we optimized his sedation so that he could be awake. He got his day-night sleep cycle going, and we made sure that his fluid balance was not too positive. And with all these, we were able to make him recover and be ready for extubation as soon as he was decannulated from the ECMO machine. So in terms of this case, the unique challenges that we had was the decision to go on to ECLS for ARDS in a child with sickle cell disease. He was our first patient with sickle cell disease who kind of needed ECLS. But again, with a multidisciplinary team, and we also asked ELSO registry for their help. And with that in place, we could take that decision pretty quickly. Sickle cell disease consideration while on ECMO or ECLS, again, because he's had this Harlequin syndrome and desaturated blood in the upper part of his body, whether it could precipitate sickening was a question. But we were able to convert him to VB ECMO pretty soon. In terms of his neurology, there were no concerns. He had an MRI after the PICU admission, which was again normal. So there was, I mean, hopefully this hypoxia didn't cause any issues with vasculitis or thrombosis. And ensuring early rehab while on ECLS therapy. Again, this was something that all the multidisciplinary team took up as a challenge. And with the family to support us, we could demonstrate that it is it is easy. It is possible to do it. As a trainee myself, I was a bit concerned whether with the ECMO cannulas and with sitting in the bed or doing cycling on the bed, would that cause any problems? But learning from this case, it is something that is possible, and it is something that we should do more for our patients. So this is him coming back to us a month after his PICU admission. And again, he was back to being healthy. He even taught us how to do the floss dance on the unit. And yeah, so we were able to manage his ARDS, though it was really severe, and the outcome was good. These are some of the references that I have used in my talk, and thank you all for your attention.
Thank you, Swaroop. So it demonstrates to us a few things, that even though you're in a high-income country, there's certainly things that you can do that our colleagues will do in a low-resource country as well. Communication is really important, and coming back to the basis of your clinical assessment. And it brings to me great pleasure to introduce Martin Niebuhr, who is a fantastic colleague and a friend that we've met during the course of the pandemic. And Martin has been supporting a lot of training and teaching at Birmingham Children's Hospital on our teaching program. So today we've asked him if he can give us a special talk on ARDS. Martin is the Chief of Division of the Pediatrics Critical Care in PARDS Children's Hospital in the Netherlands, but he's also the President-elect for EFSMIC. Martin is well published. He's published over 180 scientific papers, and he's given a number of talks around the world at many major conferences. His main academic interest relates to pediatrics mechanical ventilation, and he's the PI for the Pan-Pediatrics ARDS neuromuscular blockade study and a number of other studies, including the prospect study that we've just heard of. So I do not want to use up too much time. So over to you, Martin, and thank you so much for being our first expert speaker on this webinar.
Thank you very much for this really kind introduction. And it's a real honor to be part of this inaugural webinar. And it's also bringing me back to earth, listening to your stories, by realizing that what I would see as normal is not so normal for many of us all over the world. And this is really a fantastic series of webinars that's really necessary. So thank you very much for bringing this up. I will see if my screen is now full. Is it okay? Perfect. So the question is talking about the, let's see if I can make this up, the differences between low and high resource countries in ARDS, differences and challenges. Well, these are my conflicts of interest to disclose, although none of them are related to the topic of this talk. And this slide was shown in one of the presentations before, and I think this is a very fascinating publication shown published very recently, discussing the issues that there are regarding respiratory management in resource-limited settings, highlighting the issues with mechanical ventilation, amongst others, the absence of training or technical support, no biomedical engineers, a compressed air source needed to run. I mean, and that's what I said in the beginning, understanding that what is normal for me is not that normal. I just plug the device in the wall and I get the air, but this is not the case for many of us. So yeah, this is a really fantastic paper to read. And what the group also discussed is, okay, how can you address these issues and what might be potential solutions and they propose not only avoiding intubation, but how to improve patient safety, liberate them from the ventilator, and try to prevent ventilator-induced lung injury. And they provide a cascade going from a reliable oxygen supply and pulse oximetry to non-invasive respiratory support, and in the end to invasive mechanical ventilation. But, well, reassuring, we face the same things wherever we are all over the world, because there is so many things that we don't know. We don't know about pediatric mechanical ventilation or non-invasive respiratory support. It's still a black box, despite the fact that we are doing this on a daily basis in our intensive care units or wherever we are. And if you are in the incremental phase of the disease trajectory of the patient, there are so many questions open regarding high flow nasal cannula, conventional mechanical ventilation, when and how, and should you allow for spontaneous breathing, And when do you need to go to high frequency, and how do you need to use high frequency? And if you have ECMO, when do you need to go to ECMO? And then the same questions when the patient is improving. How do you wean the patient? When do you do extubation readiness testing? How do you do these testing? And will you go for non-invasive ventilation after extubation? Will it be prophylactically or on medication? So many questions are still out there. And it was a little bit discussed about the definition. And I think this is important because if we want to understand ARDS and understand the difference and challenges, we need to talk about the same thing. And for many, many years, despite the fact that in the original publication by Ashbaugh in the 1960s, children were included in his case report, for years ARDS has been seen as a adult respiratory distress syndrome, although they use the A for acute and not adult. And the Berlin definition was proposed about 10 years ago, discussing, okay, this patient has ARDS if it's within 1 week of clinical insult, has bilateral opacities, and oxygenation was stratified into mild, moderate, severe, and that was clearly correlated with mortality. And Berlin works in children. One of my colleagues, Daniel De Luca, tested this in infants, where he identified mortality or ECMO mortality as combined endpoint, and Berlin outperformed the previous AECC definition. And this is from the Brazilian Pediatric Acute Respiratory Distress Syndrome group, where they compared AECC with the Berlin, and they found more or less the same, that Berlin identified more patients and was better correlated with mortality. But the issue is that there are many things with the Berlin definition that make it a little bit more difficult to implement it in PEDS. And Robbie Kamani sat together with Doug Wilson and Neil Ferguson discussing this, and well, one of the most important features in why we need a pediatric specific definition is the lack of invasive measurement of oxygenation. And Berlin had a lot of other things, including bilateral infiltrates, but we know that in pediatrics, well, do you need a chest radiograph? Can you get a chest radiograph? And how relevant and what's the relationship between the chest radiograph and, for example, CT? So how useful is a chest radiograph? And all these uncertainties and these difference between adults and children ultimately led to the PALIC pediatric ARDS definition, was shown in one of the previous talks before. And it's a really nice definition. And at present, we are working on a revision, leading to lots of discussions, including one of the questions that was asked in one of the presentations: do you need a chest radiograph? Or do you need imaging at all, or do you maybe need to exchange it with a lung ultrasound? But for now, in our pediatric definition, we have more or less the same as what the adults have. So within 7 days, respiratory failure not explained by cardiac failure or fluid overload, and a chest radiograph consistent with acute pulmonary parenchymal disease with 1 or more bilateral infiltrates, but not mandating bilateral infiltrates. Oxygenation stratified using the oxygenation index and the oxygenation saturation index, and that correlates really well with mortality. The benefit of this definition, as outlined before, is that there is a metric of oxygenation that does not mandate invasive indwelling arterial lines, which is the OSI. But the thing is, well, not ARDS is ARDS, so we need to unpack it. For example, if you have a patient with a viral pneumonia, at least in the resource-rich countries, it has very low mortality. So not the same. RSV, for example, in other countries might be associated with much more mortality, as we know, but not ARDS is the same. So we should really unpack the syndrome, calling for a personalized medicine for ARDS. And in adults, this is really emerging. And I think for PEDS, we will see this in the next coming 10 years as well. So what do we know about the true incidence of the mortality of ARDS? Well, Laura Schouten from the Amsterdam group summarized the existing data, which is mainly using the adult definitions at the AECC in the Berlin. And they found a mortality, pooled weighted mortality that was different, whatever endpoint you would use, but it was somewhere between 26 and 34-35%. This is a really nice study, which clearly shows that most of the data is coming from research-rich countries and Asia, but for example, Africa is really missing in all the data. The other thing what they really strikingly shown was that the mortality was different by geographical location. So in the Western countries, they found an average mortality of 27%, whereas it doubled in the Asian countries. And the publication of PALIC was followed up by the PARDS study, which is a really nice point prevalence study establishing the prevalence of ARDS using the new PALIC definition, led by Robbie Kamani, showing risk factors that are almost the same as we had 10 years, 20 years ago, so pneumonia and sepsis. And again, PARDS was a really nice study showing differences in outcome, because the mortality was higher in South America or in Asian countries. But again, this study suffers from the fact that Africa is missing. So we have this black spot on our map where we don't know what ARDS and how often ARDS occurs. And we got some glimpses from the previous talk that it's really prominent. So a next PARDS study should really try to be global, in a true sense that it's global, that we need to include Africa as well. What we learned from the PARDS study is, because there was a lot of data collected, that we could identify predictors for mortality. And then another Yea published this in the Critical Care Medicine, where he identified that especially the presence of a immunocompromised or a organ failure, so the pediatric logistic organ dysfunction score, was highly predictive of a poor outcome. And that is, I think, something similar for wherever you are all over the world. And what we also learned, and this is from coming from India, is that there might even, similar to the adults, be a difference in pulmonary and extrapulmonary ARDS. And that this difference in pulmonary and extrapulmonary ARDS, so extrapulmonary ARDS caused by sepsis or by trauma or whatever reason, is associated with higher mortality than the pulmonary ARDS. And again, multiple organ dysfunction is a really prominent cause of mortality. So it doesn't matter wherever you are on the globe, the fact that ARDS is important and it has a high prevalence and has a high mortality, and that most patients die not from ARDS but with ARDS, is something that we all need to work on. Same thing we looked in the PARDS study was the use of adjunctive therapies. And I think this really underscores the availability and the geographical differences. This is a so-called heat map, and the darker the color, the more often a adjunctive therapy is being used. And so you have neuromuscular blockade, so CEMB, the inhaled nitric oxide, steroids, prone positioning, high frequency, and ECMO. You see that in some countries there is no ECMO available, so that's 0%. And high frequency is then more prominent in the countries where there is not ECMO. And then they dichotomize into high income and middle income countries according to WHO definitions. And you see a striking difference in the use of adjunctive therapies. And this means that if you're going to perform studies or if you're going to develop educational strategies, you need to take this aspect and this geographical difference into account. So if you have a patient with ARDS, what would be then the first step? Well, ASPMIC developed using the PEMVIC recommendations a guideline for COVID, but I think it's more or less the same as for non-COVID ARDS, and it's freely downloadable from the ASPMIC website. That in most patients who have a at-risk PARDS or have a mild PARDS, characterized by the PF ratio or the SF ratio as shown in the blue bar, you can safely go to a non-invasive approach. And depending on what you have available, CPAP bilevel and IV, and if not available, high flow nasal cannula. The only thing is that if you go for a non-invasive intervention, which would make sense, you need to carefully evaluate your patient and do not hesitate to intubate if the patient doesn't improve or if the patient deteriorates within a 60 to 90 minute time frame. The question is a BiPAP better than high flow nasal cannula, and what identifies failure? And I left out in this document the bubble CPAP studies that there are published in resource limited countries because they were not specifically targeted to ARDS but to a more general population, so the ones with pneumonia or whatever, but they clearly showed that bubble CPAP is better than no CPAP. So what identifies failure? Well, for this we have to go to the adults, and the adults published in the New England Journal of Medicine. They did a randomized controlled trial, but they compared 10 liters of oxygen versus high flow nasal cannula, targeting a similar stature oxygenation. And they found that especially in those with moderate to severe ARDS, the patients who were randomized to high flow oxygen had a better survival at a lower likelihood of getting intubated than those who were in non-invasive ventilation. So if you don't have non-invasive ventilation, or if you don't have much experience in non-invasive ventilation, this would suggest that if you have high flow nasal cannula of high flow oxygen, this probably should be your first tier therapy. This is the survival curve for that same group. And this is quite interesting, and it probably has to do with interfaces and asynchrony, all those stuff, and that's something you don't have to deal with when you're on high flow oxygen. And for PEDS, we do have some data from Spain, from Juan Madelma Colunga and colleagues, showing that the SF ratio, a non-invasive metric of oxygenation, so the saturation divided by the FiO2, was predicted for non-invasive ventilation failure, and a drop at 1 hour of start of NIV, best ident failure. And again, failure rate was extremely high in that group, about 50%, indicating that if you put a patient on non-invasive respiratory support, you need to closely monitor that patient and escalate with a low threshold. The adults try to identify another thing, and this is quite interesting because these are the right graphs from adults who are non-invasive ventilation, and they found that their respiratory drive, exemplified by the mean tidal volume, was a predictor for failure. And those with a severe ARDS, so PF below 200, if they showed signs of vigorous breathing, making large tidal volumes, were more prone for NIV failure than those who had a tidal volume of about 8 ml per kg. So if you have a patient on non-invasive showing vigorous breathing, then you should be aware that this patient is very likely to fail non-invasive respiratory support. And then if you have to intubate, well, then you have to go to the concept of lung protective ventilation. And although they seem quite intuitive, they are somewhat difficult to apply at the bedside, because this is a pressure volume loop with the red line being the inflation limb and the green line being the deflation limb. And there is only this really small safe zone of ventilation where you can safely vent the patient without being injurious. And we don't want to be in the upper part of the pressure volume loop, because there you are in overdistension because you're delivering too large tidal volume. And you don't want to be in the lower part because there you have atelectic regions leading to atelect trauma. So you have to deliver a optimal tidal volume, a small tidal volume, and an optimal level of PEEP. And nobody knows what small tidal volume is, and nobody knows what optimal PEEP is. Because in the adults, well, we of course know this randomized controlled trial in the New England Journal of Medicine, 6 versus 12 ml per kg ideal body weight, one of the most cited study. And those who were randomized to 6 ml per kg ideal body weight had a better outcome than those who were randomized to 12. And note the differences in plateau pressure. So the ones who were randomized to low tidal volume also had lower plateau pressure. But if you look closely into these patients, and this is adult data, unfortunately, is that there is still a group of patients, and you cannot see from the outside, that those patients still have end-tidal regional hyperinflation, indicating that 6 ml per kg is too much, and those patients might go to 4 or 3 ml per kg, or might be oscillated. And that would fit with the concept of the baby lung. And the baby lung, developed by Gattinoni a long time ago, states that you should not normalize tidal volume to body weight, but rather to the amount of inflatable lung volume, so to total lung capacity. And the thicker the lung, the smaller the TLC, hence the lower the allowed tidal volume would be. One of my colleagues summarized the observational pediatric data, because we don't have randomized controlled trials. And again, there was not a single threshold of tidal volume to be associated with increased mortality in PARDS patient and in non-PARDS patient. And stratifying by groups showed the same results. So we don't have that answer in PEDS yet, and the trial is going to be really difficult. And this is, as I said, the lung compliance dictates optimal tidal volume. And that's why I think that if you have a patient with lung injury, there is no sense for ventilator modes that require setting a volume, because you don't know the volume. So please, everybody, get rid of PRVC on your device. It's a useless mode. Because if you have a patient with mild ARDS, you can give a large tidal volume. But if you have a patient who has severe ARDS, compliance is poor, and then a smaller tidal volume is allowable. So who knows what tidal volume you would need to set during the PRVC? Well, this is the pediatric data, and that's quite interesting, because the adults found lower tidal volume associated with better outcome. The pediatric observational data found that higher tidal volume was associated with better outcome. not only the study from Simon Erickson in acute lung injury, the cohort study by Robbie Kamani in acute hypoxemic respiratory failure, and the study coming from China, they all found the same signal, that the higher the tidal volume, the lower the mortality. And that's quite interesting. And this probably has to do again with the poor compliance. And because Robbie Kamani went back in his data and found that the lower the lung compliance, the lower the tidal volume was this going to be delivered. And in fact, it was what the adults did before they randomized those adults to the ARDS network trial. So this is data from the adults randomized in that trial. And pre-randomization, those with really sick lungs had lower tidal volume than those with really with quite good compliance, indicating that those patients who had a good compliance, higher, who were randomized to 12, had good outcome. But if they were randomized to 6 ml per kg, they had actually increased mortality. And patients with a low compliance who were randomized to 12 ml per kg, yeah, for sure, they did poor. But then when they were randomized to 6, they did actually better. So it's really important to understand the lung compliance, or at least the respiratory system compliance, when trying to ventilate your patient. This I will skip for the sake of time. Then we go to PEEP. Same as for PEEP. Not all PEEP is PEEP. Here we have 2 patients, one on the right, or on the left with a homogeneous lung disease, and on the right with a focal ARDS. And if you, in the left patient, if you would increase your PEEP, you would really get better lung aeration. But in the right patient, if you increase your PEEP, you are going to over-distend areas that were already normally aerated, really causing harm to the patient. And knowing this, that there is not just one PEEP, then we need to find again, okay, what identifies our optimal PEEP? And it suggests that the compliance corresponds with the best level of PEEP. So this is physiology, and this has nothing to do with the ARDS network grid that was developed by adults, which is a cookbook approach saying, okay, if you have this IFI2, then your PEEP should be somewhere with this, because this has not been validated, it's not physiology, and it ignores the differences in responses to PEEP in your patient. The only little bit tricky thing about this is and this is data coming out of Los Angeles and Philadelphia, is that in pediatrics, we are afraid of using PEEP. So rather than increasing PEEP when our FI2 is greater than 0.6, we tend to accept higher FI2, as that's really nicely shown in the study as well. And in that same study, what they found was that non-compliance with the grid, so the more the patients were off the grid, and again, this is an American study, the higher the mortality in all ARDS patients and in those with PF below 100. So that doesn't mean that the grid is 100% the way to go. At least it shows that we need to increase our PEEP level if we have high FI2. The adults more or less found the same. So all the randomized controlled trials comparing high versus low PEEP, they could not find a beneficial effect, and the authors concluded that probably in an unselected group, high PEEP should not be used, and that you should really try to identify the patient that probably benefits from a higher level of PEEP. And Amato more or less linked these things together in the driving pressure, which is the ratio of tidal volume over compliance under zero flow conditions, really important, showing that if you lower your driving pressure by increasing your PEEP, then you would have the best outcome of your patients. And again, this fits with the concept that the compliance of the lung dictates the volume that goes in the patient. I will skip this one for time because this is, although really interesting, because all the aspects of ventilating loose lung injury boil together in this one, which is the mechanical power, but we can talk a year about mechanical power. Proning, I would like to mention, because proning is easy to do, is cheap, and can be done by everybody wherever you are. And the idea behind proning is you get a shape matching, and that the effect of gravity becomes different on your patient. So in the above panel, you have a patient with supine, and because there is gravity, you see that the dorsal lung parts are collapsed, and the heart weight pushes on those dorsal lung parts also. If you put a patient prone, so if you flip a patient, then the heart is on the top, and the gravitational effect of the heart is gone, and you get a better distribution of the transpulmonary pressure. Problem is that in pediatrics, we don't have outcome data showing that it works. This is the trial from Martha Curley, published almost 15 years ago now, with acute lung injury, where they did confirm that proning improved oxygenation because the PF ratio increased and the OI dropped, but the outcome was completely the same. And probably this is because they included in that study patients who were not really sick enough, because the adults went back in their data, and what they found was that if you only applied prone positioning in the really severe ARDS, so the PF below 100, there was a true benefit effect on mortality. And this led to the prone positioning in ARDS trial, randomizing adults with PF of 150 or low to prone versus no prone, and then they show a really significant effect on patient outcome. Mortality in the group randomized to prone positioning was significantly lower. So if you have a patient with severe ARDS, let's say PF below 150, and you don't have anything else, then proning is the way to go. Neuromuscular blockades is a different discussion, often used, as we saw in the PARDS study, but there are opposing results because we have the first study on the left from Papaziel, the French study, showing a really effect on mortality, a positive effect on mortality in adults with ARDS randomized to neuromuscular blockade for 48 hours, whereas more recently the Rose trial was published and they found absolutely no beneficial effect and maybe some more harm. So routine indication of neuromuscular blockade, no, and maybe in a targeted patient group, although we cannot identify it at this stage, yes. For high frequency, really used, and I'm a high frequency fan, and probably Zef can confirm that, but high frequency, you have a problem because the pediatric data and the adult data are not in favor of us using high frequency. No study showed a beneficial effect on outcome, and some even showed harm. The adult trials, especially the Osprey trial, showed higher mortality in those randomized to to high frequency. And this led to the conclusion, at least also for pediatrics, that it might be the end of the road. But I really would like to argue that any trial can almost kill a good technique, and that we really don't know how to use the high frequency oscillatory ventilation properly in critically ill children. Because what we do is an open lung strategy, so a full recruitment, oscillate on the deflation limb, and we achieve this by a staircase recruitment and not a sustained inflation like done in the adult trials, or many people don't do a recruitment at all. We use the highest possible frequency, so irrespective of age. So frequency has nothing to do with age or weight or whatsoever, but it has to do with lung compliance, and I will show you one slide later on. And we start 12 Hz in all patients, in the 3-month-old baby and the 16-year-old child, and a high fixed power setting. So we target an initial proximal pressure amplitude of 70 to 90 and then never ever touch the power button again. And such an open lung strategy is feasible, as we really recently shown in the annals. So although having a high mean airway pressure in ARDS patients, you can achieve frequencies that are well above 8 Hz. And despite this high frequency and this high pressure and this high power setting, you really improve oxygenation. You see a nice drop in the OI, especially in those with severe ARDS, and an improvement in the PF ratio. And despite the high frequency, patients had normal pH and could really easily be ventilated. So the pH over time was between 40 to 60 millimeters of mercury. So it improved oxygenation and it gave a good CO2 clearance. And all this high pressure and all this high frequency didn't impair hemodynamics. So the heart rate normalized, improved, mean blood lactate stayed constant, and blood pressure stayed constant, and the central venous pressure dropped also in these patients. So having an open lung strategy using the high frequency is really, really helpful. So many mechanical ventilation for PARDS, many unknown unknowns, only few known knowns. Well, disappointingly, our daily practice is hardly supported by any rigorous scientific evidence. So all of us, wherever you are on the globe, we need to collaborate and do studies. Unfortunately, much of what we do is based on anecdotal experiences, institutional beliefs, institutional preferences, and to a certain degree extrapolation of adults. And I think this is really something we need to change. We try to summarize this in the PEMVIC recommendations. This is an open access paper, so it's freely downloadable from intensive care medicine, discussing, depending on where you are in terms of disease severity, what kind of monitoring should apply if you have it available. But again, this is with the research-rich country glasses on, so we really need to change this in the revisions. But I think this is a really important one, summarizing how you should approach the patient with ARDS, going from a change in tidal volume, change in PEEP, high frequency. And with that, I would like to thank you for your attention and happy to answer any questions. And I'll stop sharing if I can do this.
Thank you so much, Martin, for an amazing presentation. I think we all learned a ton. We have a number of questions in the Q&A, and I will try to go through them. So first of all, somebody asked about how to access the recording of this lecture, and the answer is yes. So all registered participants will get the recording of this webinar, and it will be put on social media and on the WFPICCS website. So you can pass it on to friends and family. So let's go through some of the questions. The first was by Brenda Morrow from South Africa. Thank you, Brenda, for your excellent question. So you made a comment on why doing manual CPT, so chest physio in patients with pediatric ARDS, there's not really evidence for it. And I think it was partially, and I agree with you, I think it was partially answered that it's only done as needed, and in many settings, in low resource settings, there's no humidification. But I wonder if any of our speakers, maybe Adnan, can you expand on that briefly?
Thank you for the question. So yeah, so many of our patients have a really wet chest, and getting out the secretions would be difficult. So actually it is not, it is only prescribed really when necessary, and we avoid disconnecting the vent, and that's why we said inline suctioning is one of our challenges. So we try to avoid chest physiotherapy as much as possible, and only do if really necessary.
Excellent. Thank you, Adnan. Let's move on to one of the next questions by, I'm sorry if I'm not saying the name right, by Hilden Juma, is asking about any experience with APRV setting for difficult recruitment. I think, Martin, this is a question for you.
Thank you. That's an intriguing question about APRV, because we have the recent paper from Riri Ganashan, who was in India back in the time, but he's now in, I think somewhere, he works in Canada, showing that APRV didn't really improve patient outcome. And well, the idea of APRV mainly is that it's a ventilation mode that gives high inspiratory expiratory pressure, but also allows for spontaneous breathing at the same time. But then I would think if you have a patient who is really severely sick and has severe ARDS, why would you allow for spontaneous breathing during that disease phase then? And then I don't think there is real room for APRV. I think only when the patient starts to improve again, then probably there might be a place. But that's something that really needs to be explored. And it's a really difficult mode, how to set the time and how to set the drop in pressure, etc. It's a really complicated mode. People complain about high frequency being complicated. Well, APRV is even much more complicated.
Thank you, Martin. One other question by the same participant. Any comments on safety of bronchoscopy in severe ARDS and high ventilation settings? That's certainly something we all struggle with.
Yeah, that's a fantastic question. We don't do routinely bronchoscopy in those patients because of the fear of de-recruitment. But if we have any evidence of blocked endotracheal tubes or blocked airways, then we do. But that's not that frequent, and well, we do stimulate our nursing team to do closed endotracheal suctioning as often as possible, because then you don't get a really serious de-recruitment. That's fine. But I mean, if you do the bronchoscopy, you need to decouple the system so you get de-recruitment. This goes a thick bronchoscope goes in the patient, and the tube is blocked. So I think it's something that's really last resort in the ventilated patient, not in the patient who is on ECMO, but it's a different situation.
I think this demonstrate that sometimes when you have all the resources available, the clinical assessment of what's in front of you can sometimes be distracted by what you have available. So for example, if I'm working in a low-income country and the patient is similar in a high-income country, I might probably not be thinking, oh, I need to do a bronchoscopy here, because my backup situation or what is going to get me out of the situation should I deteriorate, is not available. And this is where we learn from our colleagues in low-income country, because we might have the same patient and they manage the patient one way because of their limited resources. And we have the similar patient, and because we have these resources, and then one wonders which is the right thing to do at that point in time. And I think that is what this session here is, to help us to learn from each other. It's not because you have something available that means that you must use it. So a really, really important question. Thank you very much for asking it.
All right. And the last person by Dr. Behelden, if you have a patient with an OI of 30, what would you do? High flow versus ECMO? What is your protocol to decide? Another $1 million question.
So a non-intubated patient with an OI of 30 probably would be
I would think the patient would be intubated.
Yeah, that's it. So a high flow, I mean,
I think probably they meant high frequency.
Yeah.
So
Yeah. So well, I'm a bit biased because I have a really low threshold for high frequency. We have a protocol in our institution where we say, okay, if a patient has a plateau pressure of 25, 26 and a PEEP of 8 or greater and an FiO2 of 0.5 or greater, then we probably go to the oscillator. If you have an OI of 30, well, then at least in our unit, the patient would have already been long on the oscillator. If you don't have an oscillator, I would definitely have proned that patient. And if you're in a resource-rich country where you have ECMO, people would have already cannulated the patient, but then I would still first use high frequency, because I think oscillating a patient is less invasive than cannulating a patient. Although John Lilly from Evelina will think otherwise, but yeah, so if you have OI 30, high frequency, definitely.
I think most places will use high frequency and use the other strategy that we speak of, because there's certain risk associated with cannulating a patient. It might be easier. You might be supporting the lungs in a VV sort of situation, but you're anticoagulating the patient. There's so much more risk associated with it. So one will try those variant strategy. Of course, you wouldn't go on and on and on. And that's where it comes up to a multidisciplinary discussion as to what you're trying to achieve with your management strategy. And then if you're not achieving those, as Martin alluded to earlier, you set your goals. And if you're not achieving that, you rediscuss, and then you move on from there. Yes, and I do think, Joel, yes, thank you, Marlon. So Marlon is from Evelina, one of the other intensivists there. And John is one of our colleagues from the UK, and he has a big interest in managing patients, and he's done a lot of work on VV in these
he's doing excellent work, and I'm teasing a little bit because we had a really good pro-con debate just recently. Well, of course, we ended on the same page, so no worries whatsoever.
All right, great. We're going to move on with some more questions. And so the question here, what is the current evidence of starting steroids, if any, in pediatric ARDS?
Again, we don't know because we don't have randomized controlled trials. We do have some observational data, but they are very much affected by the fact that a lot of children who come in with ARDS already had some form of steroids from whatever reason, because they had asthma or whatever. So, well, this is something, and that's going to be reflected in PELIC 2.0. It's something that really needs to be studied, especially since the adults just recently published a trial where in all comers ARDS, they found a beneficial effect of dexamethasone for 10 days. So it's a really fascinating area, but we do need, and that's why I really call for a global collaboration, because we need to understand when to ventilate, which mode to use, which setting, when to use which adjunctive therapy. I mean, there are so many questions that need to be addressed. And that's something that we only can achieve if we do it together.
And this would certainly be an intervention that could be done anywhere, giving steroids. So it's a very important question.
Absolutely. Yeah, absolutely. Yeah. Yeah, and
Next question.
it would be really fascinating. Sorry, in that case, because if you look, for example, in countries where there's a lot of dengue fever and with a lot of sepsis, I mean, yeah, then you have two beneficial effects of the steroids. So it would be, and then you can compare it with other parts of the world. It will learn us so much.
Absolutely. The next question is from Dr. Habtambu Sime. Hi, Habtambu. He's from Ethiopia. He's asking, can underdiagnosis of pediatric ARDS affect prevalence in the low resource settings? I would say yes, unless we have a good diagnosis that works for all settings. I would think so, but maybe Martin, you have another thought about this?
No, I agree. And I think Adnan discussed this in his talk as well. What's really quite interesting, and I have to read it because it came out last week, in the adults, Gattinoni and Marini wrote a provocative commentary, and I like being a little bit provocative, so I like that kind of stuff. They're calling for maybe abandoning the term ARDS in adults. Lessons learned from COVID. Do we really need to use the term ARDS? So that's maybe in 10 years' time we think something completely different. But it's true that in PEDS our prevalence was low, not because we don't see ARDS, but because we like to call it RSV bronchiolitis, or we like to call it pneumonia, or we like to call it sepsis with lung injury, and we don't label it ARDS.
That's very cool. So maybe you should start thinking of a good name. Yeah. All right. Next question is actually about the PICU fellowship by Dr. Natwachu Daniel Kabo, asking about fellowship opportunities in countries like Cameroon. Well, we don't have a fellowship there right now, but you can send us your interested trainees, and I will put my email address in the chat, so anybody who is interested in having trainees sent to our program in Kenya, please contact me, and I will help you. All right. Okay, so a question directly to you, Martin. What mode of ventilation do you prefer in your unit for ARDS? Ooh, it's a very general question.
We start in patients with lung injury, irrespective of lung injury, on pressure controlled. And in the young infants, the assist control mode, and the old infants and older children, the SIV mode of pressure controlled. And then as soon as a patient who has more severe disease and patient hits criteria, we go to the oscillator. Yeah. And there was one question in the chat about PRVC. I mean, I think if you have really mild lung injury, or if you have healthy lungs and ventilate for any other reason, then PRVC, of course, is a fine mode. But if you have moderate lung injury or severe and you don't know what the tidal volume is, then I would really not use PRVC. And not even AC or SIV, it doesn't matter. Just forget about PRVC.
All right, that's the one learning point from this lecture. All right, thank you. So here's a question about neuromuscular blockade. What do you use for paralysis and ARDS, and do you use it continuously or bolus? What is the evidence?
That's a lot of questions in one. Well, evidence in PEDS, there's none. Evidence in adults is conflicting. My practice is that in moderate to severe ARDS, we use it for 48 hours. And I'm running a trial in the Netherlands. So hopefully in a few years' time, we will have an answer.
Even though you run it continuous, I think they focus on the outcomes, as Swaroop has been mentioning in his talk, is that even though you have this patient that is significant to ventilate, you want to still give a rest period, or what we call it a holiday here in the UK, because one needs to understand the clearance of these sort of drugs. So renal, you look at your other organ injury. So even though you have it in the system, you should give them a pause in muscle relaxation, and then you restart, because just stopping it for a wee bit of time wouldn't cause significant changes. The patient wouldn't wake up immediately and start to cough to cause more injury. And that is our practice here in Birmingham, to give pause, a holiday, on rock. I don't know if Surup wants to say anything else to that.
Yeah, exactly. I think we do a rock holiday. We assess the patient for their movement. We can sometimes use strain of 4 as well to see if the neuromuscular bucket is wearing off. And then at the same time, you can see how they are tolerating it from a ventilatory point of view, so that they don't build up all this neuromuscular blockade and lead to critical illness neuropathy.
Yeah, we do a rock a holiday as well, unless there's real severe areas. Then we just put them on 48 hours and don't do a holiday. Then we keep them paralyzed.
Great, thank you. There are a few questions about how long you would keep a patient on high flow, yeah, what's the maximum amount of time you would keep somebody on high flow until you sort of change to the next mode?
I think, Emily, I think the high HF is high frequency.
Oh, that's what I mean. I'm
yeah.
sorry. I keep saying it incorrectly.
It depends. I mean, if you have a patient who's on high frequency and we've recruited and the patient is stable, then we keep them on and we even extubate from high frequency. But if you have a patient on high frequency and there is you cannot wean the pressure over time or the FO2 increases, then we have the option to go to ECMO. Then we move to ECMO.
Yeah,
Great.
I think that's a benefit in the high income country.
Yeah.
Some people in some units, they convert back to the conventional and use that to wean, whereas in some unit, I think you can just extubate from the high frequency as well. And I think mostly you find that in the neonatal unit in the UK, but in other countries, like you said, Martin, you can just, get the lungs are better, just take the ventilator off.
Yeah, we tend to transition to conventional. I think this is just what we're used to, but I don't know about the evidence behind that.
Yeah, that's a good question. I mean, nobody knows.
Great. We have an interesting question here from Dr. Kristen Henley from San Antonio, who is asking about the use of proning on non-invasive ventilation in cases of mild ARDS, because we've certainly been doing that with our COVID patients. And so the question is there utility to do that in general with non-COVID patients? And that's a really good question.
Yeah, that's a fantastic question. And I think the thought is really appealing. And well, we don't have any pediatric data, but we do know from the adult data that those with mild to moderate ARDS, there was no outcome benefit of prone positioning. But again, those were invasively ventilated patients. So it might very well be that if you have mild to moderate and you can breathe spontaneously on non-invasive ventilation, that you would definitely benefit from prone positioning. And I think that's one of the lessons indeed learned from COVID that's going to be explored in the adults now.
Great, and this is certainly just like Adnan presented. It's one of the things that you can do in low resource settings. Again, it requires a lot of staffing, but especially if you can do it during the day when you usually have more staffing available, that's certainly a therapy that you could try to offer. All right,
and I think that answer the question that Shalu Gupta is asking about proning the child on a high frequency. Yes, you can prone on ECMO, you can prone on high frequency. It just requires a lot of resources, clear communication when you're doing these procedures, so that you don't find yourself creating an incident. So indeed, and we actually would probably use proning on the high frequency before going to ECLS in some occasion. I'm sure that Martin does that over in his unit. I'm not, Amelie, do you guys do the same?
Yeah. Yep.
Yep, exactly. Okay, here's a question about suctioning. Is closed suctioning better than open in ARDS? And I think, Adnan, you alluded to that. Do you want to answer that question?
Yeah, closed suction is better because of You avoid the recruitment using the inline suctioning, etc.
That's exactly right. And it's tough, right? In lower resource settings where you frequently don't have inline suctioning. So you have to really think about, do I suction? And what's worse, the secretions or the underlying lung disease. So you are really in a tough spot.
That's interesting because here in Birmingham, we are not a inline suction unit. We are a disconnect and suction and recruit. We've got a fantastic group of physio here. So when we had the COVID, well, what we had in the COVID situation, there's a very interesting, somebody's just put a note in the chat. We had to then train sort of the inline suction, but our unit, we are very much an open suction unit. So it's a very interesting conversation. But I think what one needs to understand is that recognizing that when you disconnect to suction, you de-recruit, and what sort of strategy and plan you put into place to re-recruit your lungs before put them back onto the ventilator.
That's quite interesting that you are the open suctioning. We need to do a comparative EIT study.
Indeed, we do. I think we just have a few more minutes, Amelie, to go through before we come to a conclusion.
Okay. Oof, and there's so many questions. Let me pick out some good ones. All right, I don't have an answer, but I love the question. If we consider cost-benefit analysis for pediatric ARDS and resource-limited settings, what are your priorities and line of management? Ooh, all right. Anybody wants to answer this question?
Oh, that's a really great question. That's a really difficult question. For me, what I would like to hear Adnan and Swaroop's vision also, I probably would say looking at non-invasive and looking at the non-invasive respiratory support, because that's quite easy to implement and you might achieve a lot in terms of benefit. And for high frequency, it's easy because the company is pulling the devices from the market. So,
Adnan, any thoughts?
Yeah, I think I agree with Martin, using as much as possible, trying to use non-invasive, and if you have a PICU, try to use lung protective measures without using the high. We don't have a high frequency oscillator, so as we say, what Martin has said, use the SIM pressure control mode and not going to the PRVC and the PRV. And yeah, I think you can achieve. And proning is something we can do, especially when you have enough nursing care. It just requires human resource rather than very advanced machines. Yeah.
Excellent, Adnan. I think in my experience, it's actually harder than we think to implement non-invasive respiratory support in low resource settings. And I know bubble CPAP is well established for neonates, but actually for older kids, it's not that easy, and you need a higher flow rate that you don't necessarily have. And actually having all the equipment, especially nasal interfaces for non-invasive respiratory support in lower resource settings, is not that simple. So I think that there's no easy answer.
Yeah, I completely agree. One of the things that I do is adjust pieces of equipment and to deliver non-invasive support when I visit the low-income country. But the things that I teach about is the sort of basic things. Look at your fluid management, look at the nutrition for the patient, try to, turn your patient around, and generally to try to prevent getting to that phase, as Martin alluded to, is it the lungs that is creating the ARDS, or is it another pathology such as sepsis? So think about, the introduction of ionotropes rather than volume load in those sort of patients. So how can you sort of prevent the situation, or certainly try to reduce the situation of getting into a flooded lungs and creating sort of ARDS-y picture, and then to have to manage that. And I think sometimes you just need to think backwards a wee bit before going forwards, especially when you're constrained by the resources that you have in your environment.
Awesome, great. So one very last question by Nick Ettinger, and I think this is actually a great question for both high and low resource settings. So a question to you, Martin. What is your approach to figure out what PEEP to use in severe ARDS?
That's one of the $1 million questions. And I made it myself a little bit easy by going really quickly to the oscillator in severe ARDS. No, but all jokes aside, nobody knows. I mean, I know that my friends on the other side of the pond are really in favor of the ARDS network grid because it's easy to use, easy to implement. Well, I said, it does lack some physiologic validation, but there is some suggestion that, well, there might be something in there. We have no data in pediatrics regarding transpulmonary pressure using to set a PEEP, and the adults found that using transpulmonary pressure made them better set PEEP, but they didn't improve outcome. So it's again one of those black boxes that calls, well, if prospect is done, we need to do a PEEP trial. That's probably the best answer.
All right, great. Daph, I think you're the one to give the closing remarks.
Okay. So I want to thank everyone who signed in. We hopefully it's been really informational sharing and shared experience. Thank you so much, Martin, for delivering such a fantastic talk with so much learning. But I think the two people I want to thank most of all is both Adnan and Swaroop for sharing their experiences as young doctors who will be the leaders for the future. And it was really good to co-chair this first session with Amelie. We met in Singapore years ago, and since then we've not had the opportunity to meet, but we've been doing a lot of discussion and work to see how we can improve the care for patients in a low middle income country. And she's been doing amazing work over Africa in developing the program there. So thank you all very much. What we've said is that we will have another session in, I think, December. It would be focusing on acute kidney injury. And again, we will look forward to getting trainees from the global setting. So if you think you have an interesting case that you want to present, just if you can email Amelie or myself, we'll put our email addresses in the box, in the chat box. And then we look forward to hearing from you all. But thank you all so very much for attending the session, and see you soon.
Thank you so much.
Thank you.
Bye.
Thank you. Bye-bye.